Welcome back to the next session, which is called The Great Debate. So we'll see in time how great this and how debating this is. My name is John Herman. I'm a psychiatrist at Mass General Hospital, and I am medical director of the Partners Employee Assistance Program, which looks after partners, 50,000 some employees and family members. Today, in the concept of this was to bring together folks from health plans, providers and entrepreneurs of technology to provide telemedicine, and a provider himself. While many agreements and enthusiasms are present, there are still differences. So our debaters are John Jesser, who is the Vice President for Provider Engagement at WellPoint, one of the nation's largest health plans, now 34 million lives, and that's just since this morning, 36 million lives covered, including large Blue Cross Blue Shield plans, including, let's say, Anthem of Ohio. His goal is to improve convenience, access, and affordability for patients. John has a BS degree from Miami University of Ohio and an MBA from Cleveland State. Our next panelist, debater, I guess, is Ron Dixon, who's director of the virtual practice at Massachusetts General Hospital and the associate director of Beacon Hill Internal Medical Associates. And he is a practicing physician, including an emergency that he had just a few minutes ago, and we're glad that he got over here. He has a BA from McGill. Was it BA from McGill? Yeah. S from McGill. Then he studied clinical neuropsychology, went to medical school at Dartmouth, and then has been practicing at MGH as a physician. And then last on our panel, but hardly last, is Roy Schoenberg, who's the co-founder with his brother Ido of American Well. He is the CEO of American Well and directs products, marketing, and operations for this web-based population management systems. He's published widely on medical informatics and is now on the board of the American Telemedicine Association. He went to Hebrew University, where he got his MD and then his MBA at Harvard. So those are our panelists, and here's the plan for today. We are going to ask each of these individuals to open with a statement of about 2 minutes, please, and then we will proceed with questions. I will ask each member questions. They'll have 2 minutes to respond to the question, and then each of the other participants will have a minute to criticize, comment, and or sympathize. So with that, John, why don't you start out?
Thank you. Good afternoon, everyone. I hope you're doing well. Thanks for having us here for the great debate. I would like to tell you a little bit about the angle that I'm presenting, which comes from the perspective of a health plan. So for about the past 10, 12 years, I've been looking at different companies that are small and innovative, not necessarily small, but innovative, that bring solutions that help improve access to care, affordability of health care, and most recently, that are focused on the consumer experience. And some of you might wonder why a health plan cares a lot about the consumer experience. It's not usually, it hasn't been our track record. But as you look at what's going on with health exchanges, with the expansion of Medicaid, with managed Medicare, more and more of our customers are people that we're sitting across the dining room table from, convincing them that one of WellPoint's Anthem plans or Empire is better than whatever the other solution is. So we're now more and more in the consumer products business. When I look at a lot of the things that are out there, this company called American Well came to us several years ago with this concept of telehealth that would happen, that would work for anyone that had a computer with a webcam and high-speed internet. At first, we didn't know what to do with it, but I would say over about the past 3 years, we built a product and declared ourselves as the first health plan in the country to cover the visits. And the easiest way to describe it to you is this. It's 10 o'clock on a Friday night. You don't feel well. Your doctor's office is closed. So today you have three choices. You can go to an emergency room and wait and be seen eventually, and that price point is going to be north of $600 depending on whether you have insurance and so on. You can go to an urgent care if there happens to be one in the neighborhood or near and be seen by a doctor who's never met you and has no medical history, no record of you, and that's going to cost you in the $150 or more range. Third choice, there might be a retail clinic, CVS or Take Care Clinic. By show of hands, has anybody ever used those? Okay, so those are your three choices, right? Or wait until Monday and try to get into your doctor's office. Well, what we've done is introduce a fourth choice, which is you open up your laptop with a webcam, or you pull out your mobile device or your tablet, and in less than 10 minutes, you're face-to-face having a conversation with a board-certified primary care doctor who's credentialed in a HIPAA-compliant, secure, structured way, paying with a credit card, able to offer the doctor any history that you provide, and in the case of those patients that might have our health plan, their medical history will actually be imported and put in front of that doctor before they see you. So for about $49, you have a new option. And that's what we built, and that's what we're now rolling out across the country. So I'll leave it at that and
Thanks, John.
pass the mic.
Ron?
Thank you. So how many people here have actually seen a doctor? Yeah, I figure most people have actually seen a doctor. I just want to tell a couple of stories. One is actually a personal story about my own health. I think about 3 years ago, I started to develop some symptoms like fatigue when I was trying to run, and some strange nerve pain shooting down my leg. And I'm phobic of physicians. I do not like to go. So I didn't go for a long time until it was bad. So I was finally convinced to go see a doc. I actually didn't have one, so I called one of my friends who hooked me up with a physician, and the symptoms were really starting to bug me. So I went to see this person, a great internist, and after the visit, I would have to say about 40% of my symptoms went away, which is interesting. It suggests that maybe there was something about that relationship, that healing piece, that actually made me feel better. So that was my only visit with him. So he did an exam. He probably sent me a message. So he's in the partners system, so it's all secure. He sent me a message probably 5 days later. It said, "Oh, your Lyme titer came back positive." I'm like, "Really?" Because I must have gotten, if it's positive, it's Lyme from months ago. I had to go get a confirmatory test, so he sent me a message telling me where to go. I went and got it done. He then communicated with me again with email saying, "Yeah, it looks like your confirmatory test is positive." He'd already started me on the antibiotics. He sent me the message, "I'm going to start you on this antibiotic, doxycycline." I took it for a couple of days, started to feel a lot better. About 7 days later, he sent me another message asking me how I'm doing. I said, "I'm feeling great." He said, "Well, we don't really need to do a physical, so I'll see you in a year." Unfortunately, he ended up leaving and going to concierge practice before I could see him again. But I think the moral of the story is I saw him once. We had around 4 follow-up interactions, but none of them were in person. So I think that's one thing about one beauty about telehealth, is that you actually don't actually need to see the doctor for every visit. And I think that's one of the themes that I'd like to explore a little bit today. Secondly, with regards to what, I think I'm on the same page in some areas with what Roy does around using video conferencing to evaluate patients. I had a patient, unfortunately, who developed lung cancer. He was a long-standing patient of mine. And unfortunately, there was not much we could do for his lung cancer, and eventually ended up at home bedbound. And that's where I really had my first experience using video conferencing with a patient, because I ended up managing his end of life by doing these televisits. And he would be in his bed with a video camera, and we would use Skype, which was insecure, non-secure at the time, but we didn't know any better. And so we would Skype together around managing his medicines, managing his secretions, managing his health until he passed away. So we had several visits. Of course, compensation was not an issue. I wasn't paid for these visits. That's a problem. But I think those stories illustrate the power of telehealth in the basis of a relationship with a clinician. And I think if we were to integrate that into our healthcare delivery system, we might be able to cut down on costs as opposed to developing other systems that utilize professionals that might not have that same relationship. So.
Thanks. Okay, Roy?
Thank you. It's great to be here, and being here in Boston, being a proud Red Sox fan, that's even a better day than yesterday. I wanted to spend the first 2 minutes just giving you a little bit of background about where we come from. And I come from a company called American Well. We provide technology, primarily technology and services to many of the different telehealth programs that are being deployed around the country and a little bit overseas as well. We actually started off by delivering telehealth as a solution for people in Hawaii to see their physicians. Granted, it was winter time here, so this was a very, very attractive option for us. But we've implemented for Blue Cross Blue Shield of Hawaii that capability that allowed the patient and a physician to see each other when they're not in the same place. And that was really the mission statement of the company at the beginning. We said we can use technology to actually allow healthcare to be delivered. Over the years, the system has grown both in terms of its diversity and adoption, because unfortunately the barriers for patients to see physicians are very, very diverse. We think about it, usually we think of telehealth as something that overcomes distances. Sadly, a lot of patients actually don't have a primary care physician, or they have a physician, but it's going to take them 30 days to get an appointment. Or they don't have insurance, or they have malinsurance, or they have trouble leaving their homes and getting out of bed, or that just getting in front of the physician is uncomfortable and therefore they procrastinate or they do some things that adversely affect their healthcare. And in all of these cases, we found that telehealth, that ability to deliver healthcare through technology, plays a very big role. We've also learned that, broadly speaking, it's applicable both in a way of creating a tighter, closer connection between physicians and their own patients, which is really the traditional use of this technology. And also, in a very significant way, it actually allows patients that would otherwise not be able to get to a physician other than through urgent care centers and ERs to actually do that. And we've built a system that, maybe the best way to describe it without slides and demonstration, think of it as a large, giant national switchboard that allows patients to currently engage physicians who are right at that time available somewhere else. Because our healthcare system is so broken, so mal-distributed, that you may have a lot of physicians who are not in front of a patient right now, and you have a lot of patients who need to get in front of a physician, but there's no way for them to come together. And that's really what the technology does. And I think we're seeing adoption a variety of different ways, from regional Blue Crosses. A big boost came in with the national payers, primarily with WellPoint, kind of driving this forward on a national level. But now we see employers, we see retail pharmacy chains, we see the government, we see everybody jumping on the wagon, which is a blessing and a curse, because it's a wonderful thing to see this grow. And there's all these different ways where you can do this wrong. And that's part of the evolution that we're very proud to be part of. That's the background.
Thanks, Roy. Okay, so let's see if we can get some action here. To those in the control booth, what I'd like you to do is to set the clock at 2 minutes after I ask the question, so that I don't have to go with a hook here for our panelists. So you'll have 2 minutes to answer and make a statement, and then each of the others will have a minute to comment, criticize, or support. And so I'll start with John Jesser. So you've begun to offer services in some states. Why not all states? Are you covering just some patients, but not everybody?
I'll take the 2 minutes. It may not take that long, but just for everybody's background, the telehealth laws and the medical board rules around practice of telehealth are are all over the board across the country. We've come to get very familiar with what they are and what they aren't. Some states have nothing addressing it. Some states have prohibitions. Others have progressive laws supporting it. But there's really two issues. One is, can a patient and a physician establish a relationship through electronic means? And there's some states like Texas that say no. So meaning if they haven't met before, they cannot establish a relationship electronically. States like Texas require there be a presenting clinician at one end with the patient. And so some of these things they're a bit antiquated. They don't really factor in what's available today. Most states, I would say about 45 out of the 50 states, allow patient-physician to establish a relationship electronically, but then only about 28 of those states allow that physician to prescribe based on that interaction. Our position has been that, well, first of all, when you use the word drugs and internet, you can imagine the reaction from most medical boards. There's been a lot of abuse. They think of OxyContin, they think of Viagra, and these things where you send an email and you get a prescription back. So what we do is we go in and we meet with the medical board. We show them the safety, the security, the structure around the interaction, and how it identifies the patient, identifies the physician, and so on. And number one, which usually deflates the air in the room, is that controlled substances are prohibited on this platform. And we've also banned Viagra and lifestyle drugs. So anyway, we're working with each state to show them what this is. When they see it, they're usually very responsive. And when they allow, we'll be open in those states.
Comments? Ron?
Well, I found that trying to get telehealth moving at Mass General, at our organization, has been impeded by the way that insurers generally pay for things. We've been working with the big Blues and the internet, the national plans as well, and it's been a real barrier to getting telehealth rolled into the way that physicians actually practice because they cannot get reimbursed for it. It's been the #1 barrier to our larger health delivery systems starting to use this process to evaluate and manage our patients. So I would love to see the insurers take a little bit more of an open mind around helping us integrate that into our practice.
Roy?
So I think, there's no one that's more anxious than me to see this prevail and be ubiquitous and everywhere else, and I really believe that it's going to provide tremendous value. But the reality is that if you really take 2 steps back and you think about the perspective here, the notion of telehealth, that you can deliver healthcare through technology, is brand new. And it may actually have a bigger impact on healthcare delivery, I would say, and I'm sure that someone's going to kick me here, than penicillin did. And when penicillin was invented, it wasn't available the next day everywhere around the world. It took time to propagate. It took a couple of years, but then it became ubiquitous. I think we are just in the midst of that logistic change of the healthcare delivery system to accommodate that technology. If you go 10 years from now, it's all going to be here. It's going to be available everywhere. We're just the missionaries going through the motions of making that happen.
Ron, you're up next. Some say that getting doctors to do something new is like herding cats. What will it take to get doctors online? What are their worries?
So I would completely agree that trying to get doctors to do anything is very, very difficult. I think one of the issues, especially if you're thinking about primary care doctors, but most doctors, is that there's just too much to do generally, so that doctors look at other things as more to do. So if you're actually going to get doctors to do anything, there has to be a win for them, and the win usually is time. It's not all about the money. So give you a little background. With our practice, we've actually instituted a telehealth. We developed a telehealth platform since nothing really existed to suit our needs. We really have a lot of chronic disease patients, and we wanted a way that we could follow them without having them come in. So people with hypertension, diabetes, anxiety, depression. And we built a tool that allows patients to go to it to get their follow-up visits instead of them coming in. The way that we incented the doctors to use the tool, however, is we used a payment. They actually get paid to use the tool. the payment is a little bit is less than if the person came in for a real visit, but at the same time, it takes much less time to use the tool to evaluate patients as opposed to have them come in and write notes. So the solution to me is that you make it a win for the clinician so that maybe their job is a little bit easier. They can deliver the same service with the technology. It's easy for the patients, obviously. And at the same time, you give them something back. They're getting back some time in the day. They're getting back the ability maybe to see a new patient, somebody different. Maybe they can get home earlier. I think one of the big barriers, again, is not just that as physicians we're independent operators and we're stubborn, we don't like change. It's that we're kind of pressed to the gills with billing, with results management, with population management, with documentation, with quality, and actually that leaves us how long to actually see Roy and actually make a diagnosis, right? So where's it going to give?
Roy?
I think, I think Mark, Ron is actually touching the point exactly. I think it's really impossible for us to expect that physicians are going to adopt new workflows and technologies without relieving them from the need to do the rest of everything that they need to do. But the one thing, and that's just an anecdote that I would say, one thing that we've seen which was very remarkable is that we always think about telehealth from the consumer standpoint, from the patient standpoint, what it does to them, the convenience, the immediacy, the lower cost and everything else. We've seen that it actually has a significant impact on physicians too, because physicians don't have to be anywhere either. And the reality is that in order to care for patients, they don't have to have a practice and a nurse and an administrator and a record system and everything else. They don't even have to have malpractice insurance because it's really built into that product. So the reality is that hopefully telehealth is going to make physicians' lives actually much, much easier too. And I think that will be the value that will make it adopted.
John.
So I've been working with primary care physicians for many years, and I love it, especially the independent ones, because the hardest thing in the world to do is to sell them anything, right? They're the true assessor of value. They will not write a check which is coming out of their pocket unless it works, saves them time, or helps them make money. And so one of the challenges as we take telehealth solutions to them is to hit those buttons and make sure that, and you can't force technology on a doctor as well. So the things that play well with them, the fact that as a health plan we actually cover these visits now, because so much of what happens in this technology is like an office visit. There's documentation that we can talk more about money later, but so it's a chance to make reimbursed visits for them. It's a chance when they're really tired to go ahead and go home and forward their practice and know that there's going to be board certified doctors seeing their patients who aren't threatening to take their patients. And then the whole movement of patient-centered medical homes and ACOs, which when they're now in a gain share, they're now interested also in not having their patients wind up in the ER at night or in other places.
Roy, the old comic says, on the internet, no one knows that you're really a dog. So how do we know on the internet that the doc is a good doctor, that the doctor is even legally licensed to be saying what he's saying?
Right. You know, it's a great question, and the internet is the scene of so many different crimes in so many different places that if you just think about opening healthcare into the same kind of abuse, it's going to be mind-boggling. But the reality is that, we have to pick our wars. And one of the wars we don't want to fight is we don't want to ask patients to try to assess internet physicians differently than they do when they see a physician in the office. We want to keep that the same. Patients have to be comfortable with the people that they see. What that means is that when they walk into a telehealth service, whichever one it is, they need to have in front of them the same kind of things that allow them to develop that trust as if they walk in the office. For example, I think a very important thing is that if the service is offered to you by your health insurance company, that already makes it equivalent to how you find a physician today, right? You go to, if you're a Blue Cross member, you go on the Blue Cross website, you find the physicians that are part of the network and you try to make an appointment. That's one thing. The second thing is that you really need to know where they come from, whether they are board certified or not, where they trained, how many years of experience do they have, any kind of affiliation and so on. You need to be able to look at that person, so to speak, eyes, to see their face, to know, what they've done. And we need, on the other end, to make sure that this is verified. Physicians cannot go on the system and start delivering care. It's not kind of an open-ended platform. They need to get verified and credentialed and so on. And then I think the other thing that you mentioned when you talk about how good they are, so one thing that we do, which is probably traditional, is we actually do give visibility to where you work. So if Ron is working at Mass General Hospital, which is one of the leading institutions, that clearly gives him tremendous amount of credibility. And we do that, we expose that, but we also allow patients to say how good the interaction was. In a new consumer world, what the crowd says about the service they get, the experience with the physician matters, and we actually expose that as well. So there are a lot of different interventions, but we try to make it as transparent to the patient as possible.
Ron?
So I think from my perspective, as someone who has a panel of patients of, say, 2,000 patients, if I was full-time, the beauty of telehealth would allow me to have a panel of 4,000 patients. But not all of those patients actually need to see me. They could be seen by a nurse practitioner, or a lot of them who are coming in with a lot of the problems that are actually handled by Roy's team at American Well. I don't even think they don't need a physician. They need an algorithm, just like MinuteClinic has algorithms for their URIs, et cetera. So if we don't want to add dollars to the health system and fragment the health system, it would seem to make sense to try and build the tools into an overall delivery network and increase overall access to providers that way, than fragment providers with all of these different solutions. So my diabetic is calling up John Herman, who is an accredited great physician, but
Not always do I manage
right,
that, right?
Exactly. That's my concern.
John?
Okay, so real quickly on the quality thing, it takes a trained eye sometimes to know, to figure out, did they go to the right medical school, and are they this and are they that? And many in this room may have that ability, but the average consumer may not, and it's a lot to ask. So fortunately or unfortunately, really looking for a brand that you trust, some sort of a significant institution. If you saw it was Mass General, you'd have a sense of security that these doctors are actually who they are. So I think that's one of the ways on the internet to sort of sort the wheat from the chaff. There's also a temptation for people to raise the bar higher because it's the internet. And one of our clients is a technology company in California. You may be familiar with Google. One of the things they said to us regarding our online care solution is we don't want any doctors who have been in practice after residency less than 5 years. And we said, well, okay, well, let's go back and look at who we have. And we said, well, wait a minute. You're not asking that of the Anthem doctors that they're going to out in the brick and mortar world. So we got them to actually back off on that. But it's people do find it sometimes tempting to want to even raise the bar just because it's electronic.
So, John, this is for you. So on the subject of barriers, if it really starts working, the barriers are really low, it's so much more convenient. Are you worried that there'll be an over-utilization of medical services?
A little bit. What Ron was saying, fragmentation can sometimes lead to the worried well, people seeing redundant visits and so on. We're not really worried about it, though. Blue Cross Minnesota did a study. They asked people after each visit, if this wasn't available, what would you have done? And really, about 8% of the people would have done nothing. So then you actually did generate new visits that wouldn't have happened. However, the majority of those folks would have went to higher cost alternatives. And so the significant overall effect was a cost of care savings to the employer and to whoever this plan sponsor was. So the net, and to prove that, so insurance company actuaries and underwriters who are the most conservative, when we said, we want you to cover this on all of our insurance products, they did not raise the premium because they believe the data that this overall will cause actually a savings. But you do have the potential that the worried well will now have an easier way to talk to someone. Sometimes you might identify something, though, that wasn't going to be treated before.
And maybe save money.
Yep.
Ron?
So I think it depends on how you define utilization. I think it might be actually, it's a cheaper price point to have somebody call up a physician on a service and get some advice that prevents them from going to a higher cost delivery system. So I think what we found in our practice where we've really implemented telehealth is you actually haven't seen a decrease in the overall number of face-to-face visits with providers. But we saw about a 12% of our visits moved on to telehealth of the overall visits. So if we did 12,000 in a year, then around 1,400 of those kind of moved to telehealth. But some of those visits, those 1,400, then became new patients.
So
we
it
actually
improved access for the overall
So it improved
population.
access. And I think that should be the mission of the system. It should be not to fragment, it should be to improve access and then to radically kind of transform how we deliver the service as opposed to adding on other providers to see our patients when we are not available. That to me suggests that we're actually not doing the job right, that we need to figure out how we can assess the patients appropriately when they're there, and then when there's a need for emergency, we are available. And it should be through the same tools that we are using during the day.
Roy?
Well, I just think that, at the end of the day, the technology doesn't matter for that issue, right? I mean, if people want to be seen by physicians that are very worried well, or anything you want to call it, then they'll find a way to do so. I think the mechanism, the behavioral mechanism that you can use to appropriate how people acquire healthcare has nothing to do with the channel of care delivery. It has to do with how accountable are they for their actions. And there are a variety of different, relatively new, somewhat not even popular instruments like high deductibles, various methods of gatekeeping that all translate to the same thing. They say to patient, you really have to think about your healthcare and about what healthcare services you consume, because to some degree it's going to actually impact your pockets. And for some peculiar reason, people do care about their pockets just as much as they care about their healthcare, at least when they're relatively well. So these instruments will make patients think twice about acquiring services, whether it's in person, whether it's through technology, whether it's through a kiosk, I think doesn't matter. If you fast forward, that's going to be the thing that's going to matter.
So I might agree with Roy on that to some degree,
Wow.
but
By the way, he's talking out of turn. I'm going to let him.
We've done this before.
We've done this before.
Go ahead.
People care about their health care a lot and they care about their dollar a lot, but actually health care is what, 90% of health, right? So people actually, is 10% of health, excuse me. People care about their health way more than they care about their health care. And you can actually use non-doctors to provide services to really improve people's health. And non-doctors are a lot cheaper to deliver the service. Mm-hmm. Let me give you an example. So in our practice where we have actually implemented telehealth, the most important person in that practice has become the Star Trek chart woman. So she looks at all of the patients who are on the telehealth platform and makes sure that they're following up with their blood pressure checks at home if they haven't logged in. Make sure that they're following up with their glucoses. Make sure that they're following up with their follow-up visits for reflux or depression. So if they're not answering, if they haven't responded to the visit they have pending, she's the one that calls them, makes sure that they can get into the system, that they're doing what we have asked. And she has taken work off my back.
O'Hara.
Exactly.
All right.
And she's paid about $40,000, $45,000 in benefits, which is much less than a doc. And I think she's now managing about 10,000 patients. So the technology's helping and a person is helping, but it's not a doctor. I don't think it needs to be a doctor for a lot of these issues.
Ron, so, because you just told me when you came in about a patient who had a syncopal episode or something, and you thought maybe you weren't going to make it here, okay?
Correct, yeah.
So let's say you're in your office, or even it's on the weekend, and you get a call from a patient, maybe that same patient, and they are in their vacation home in northern Maine. Now, you're not licensed in northern Maine, and they've got a medical problem, and you start talking to them, and you have pretty good ideas of what needs to happen, what medicines they might need. Are you allowed to make a diagnosis? Are you allowed to offer treatment?
That's an easy question.
Huh?
Yes, thank you. Easy question. So the reason is because they're my patient, and that's why I think that's the difference between what Roy talks about and what I talk about. I'm not saying that everybody needs a doctor. When I was 20, I didn't need a doctor. When I was 25, I didn't need a doctor, and I think I would have called Roy's system then. When I'm 55 and I have risk factors, and when I get older, I'm going to have risk factors, even if I want to deny it. I'm sorry, it's going to happen to me. It's going to happen to everybody in the room. We're all going to get sick. It's sad, right?
Not me.
Not you.
I object.
So
Well, wait a minute. This is a little different, and maybe I didn't ask you right, but okay, maybe not Maine. How about Texas? They're calling you from Texas.
As long as you're my patient, it's fine. So I think that's where primary care and population management comes in. I can deliver care to my patient wherever he or she is. So she can be in Hawaii. I can call the pharmacy in Hawaii and prescribe, an antibiotic for their UTI, or recommend that they, go on propanolol and get to the hospital for chest pain. I mean, I can do that. So that's not a concern. The concern is if I'm taking care of patients who are not mine, using that system, and they're in a different state. That is an issue.
All right. Not every medical board would agree with that.
That's right.
John?
That's an area that I won't comment on as far as medical boards, because it does vary, but they may not.
You'll comment on that?
Well, I'll just say that there is so much confusion. The understanding about a physician remotely taking care of a patient is still generating visceral responses by medical board members, to the point that I've had the privilege of actually spending the day with a couple of chairs of medical boards in Washington, talking to them about a system. And one of the biggest proponents, at the end of talking and spending a day about telehealth, said, "So how are things going in my state?" And I said, "There is nothing going in your state." And he was shocked and appalled. He said, "Really, with all of these, operators and everything?" I said, "Listen, your rules are one of the most draconian rules out there of all states that are prohibiting the use of that kind of thing." And the only thing I want to say is that this is the chair of that state medical board, and he was appalled. He was shocked. Never understood for a million years that this is what his board is actually advocating, and the result is that no telehealth in that state. So the reality is, I think a lot of people have good intentions, but the level of understanding of this rapidly exploding technology is a huge barrier for allowing to do the right thing.
So I'll ask you this question. I'm getting off my own script here, but and it may apply to the health plans as well, because you can't cover someone who's not licensed in the state where they're providing care. Should there be a national medical license?
I think we're on the record.
Wouldn't
here.
that drop revenue for too much state license?
Well, so the truth is there's a cheat, right? I mean, the cheat that many physicians do today is they cross-license. And in many states, it's just a matter of kind of submitting a letter, and over time, you're going to get the licenses, and you can be cross-licensed in any number of states.
For the state fee for each of the states.
So if you want to practice, if you want to care for patients in 5 states, you just acquire those licenses, and you can be sitting wherever you want to be, but you can care for those patients. The truth is, yes, there should be one license. The unfortunate truth is, again, you got to pick your wars. And there's going to be so much opposition for opening up the state licensure that if you're going to, a little bit like what's going on in Congress, which I think has gained the appreciation of everybody here, if you tie too many things together, the result is that nothing gets done. So it's a good thing. It's a steep hill.
Better to talk to a medical board about safe telehealth than also safe telehealth, and how about if you go away and there's only one national medical board, and that's probably not a good starter.
So I think we've got time to run through one more. I'm gonna ask Ron. A lot of people say, it's all about the doctor-patient relationship, and it really can't happen through telemedicine. What about that?
So, I mean, I do believe that a big part of health care, and not health, but health care, is about the doctor-patient relationship. I think that's why so many clinicians go into healthcare. And it's not just about doctors who are providing care, but there's nurses and physicians' assistants, and all of those people are actually going to be important deliverers of healthcare, both in person and over telehealth. I do think that the establishment of the relationship, and maybe this will make me a dinosaur. I think for most patients, the establishment of the relationship is better in person. And that might not be so for the kids coming up now who are at, my son who's 11, adolescents, kids who have grown up on the internet. Perhaps the establishment of the relationship might be fine using telehealth. But for my patients who are generally a bit older, who have chronic disease, I've established a relationship with them in person, and this is not just me now, it's all the doctors in our practice have done that. And then these patients are delighted to be followed up using telehealth. After they do it, they say, do I have to come in again for this, or can I go on that thing? So I think that, and maybe this will, again, maybe like this is very debatable, right? But I think when you're talking about longitudinal care and care of chronic disease, and chronic disease is the big problem for costs for our country, right? It's not people calling in off hours for colds. Frankly, I don't care. It's the people who have coronary artery disease, hypertension, diabetes. Those are the people. If they're calling off hours for care, then we're doing a crappy job of delivering the care, and we need to change how we do it, right? So I think if everybody's taking advantage of what Roy's offering, then that makes what we do as providers look like stink, because we're not doing our job right. So that's why I think if you provide the clinicians with the right tools, and you provide those to the patients will use them and the clinicians will embrace them, and get the right incentives on board, get these guys to actually make it easy to get paid for, and then we have a system.
So, Roy, you made a point earlier, which is the doctor-patient relationship, doctor-clinician relationship is essential, and there's some places where there's not an alternative to telemedicine. It would be great if you could have it, but they aren't there. So we're talking about healthcare resource distribution.
Well, I think we all know that it's pretty miserable. We all don't enjoy seeking care, and that's because the experience is not favorable in most of the cases. But, and I agree with Ron completely that if you have the opportunity and the way to get in front of a physical physician, that you can have an intimate, in-person experience with them, great. That's by far the gold standard. That's never going to change. And telehealth, by the way, will not allow a physician to go out on the other side of the screen and palpate you anytime soon anyway. But I think we also have to recognize that, like in life, a relationship is not a one thing. There are many types of relationships, and there are many types of relationships also in healthcare. I can tell you that most likely, if you're going and having surgery, your relationship with your anesthesiologist is a very dreamy one. You don't know them very well. And the truth is that also when you go and get a consult somewhere on a lesion on your skin, you probably don't have that kind of a deep relationship with that physician. The point is that different interactions in healthcare have different expectations, different requirements, and telehealth is going to allow you to have a type of interaction with physician that has its own rules and benefits, and it's not going to be the same as things that you have with your 20-year family physician. We just need to be open to that diversity. That's all.
Okay, John.
I vehemently disagree with these guys. No. We're supposed to disagree about something, but everyone should have a relationship with a primary care physician at some point in their life. And I think no one would disagree with that. The reality is, until we enable all these patient-centered medical homes and these practices with telehealth technology so that they can expand their access and they can see more patients in person, they can be available more hours. You take the fact that that's not yet the case, but that's one of our objectives, is to enable physicians with technology to reach out and see their own patients through technology. That's ideal. Still, however, these minute clinics and retail clinics are full. ER rooms are full. Federal Express is one of our clients. They spent $42 million last year on emergency room visits for non-emergencies. So these people are seeking care in other places, and half the people that use MinuteClinic claim to not have a doctor or a relationship. So I really do think age, morbidity, those things have an effect. For the average person, myself included, once a year I need a doctor for that Z-Pack or for something. Mm-hmm. And he might remember me from last year, he might not. And it's really okay if he doesn't, and it's okay if it's not him and someone else walks in. So there's a consumer demand that will be there whether we try to solve it or not. And like water that runs to a natural place, they'll find care. What we want to try to do is make sure they find quality care in a structured, secure place, and that it's aligned with good medical care. And then...
So our time is up. I tried to get some fierce fights going here, but that's like trying to get John Boehmer, Eric Cantor, and Ted Cruz to disagree about their dislike for Obamacare. But you've done a fine job, so I want to thank John Jesser, Roy Schoenberg, and Ron Dixon for their time up here.